Good morning, everybody. It's Diwali morning. Happy Diwali. Wishing to all the panelists as well as the IHRS members and many more cardiology postgraduates and some junior consultants who will join us, who have joined us. And although it's a Diwali morning and we have got you onto this academic program, I think it will turn out to be interesting. And wishes from the IHRS Executive Committee to all of you. Now, this has been a regular feature of the IHRS academics, besides the IHRS conference, which is held once a year, and a midterm IHRS, that we do this academic program once a month on the first Sunday, about hour and a half or so, discussing different aspects related to arrhythmology. So it is about EP study, RF ablation. It is about devices, the implantable electrical devices, and at times we have non-EP cardiologists and radiologists also helping us to understand some imaging aspects of a particular disease. And I've been lucky to have a very cooperative IHRS faculty who easily agrees to be a part of this program, both as a teaching host faculty and also the moderators who bring in their expertise and have overview of what is presented. I think it turns out to be very academically very useful for the postgraduates, particularly in relation to their exit exams. The only kind of a discussion that I have with the host faculty is to keep it focused to the DNB postgraduates training requirement. So I think we will not have much more from my side. This program is going to be about arrhythmogenic right ventricular cardiomyopathy. Maybe some of the speakers will discuss it as a whole as a arrhythmogenic cardiomyopathy. Most of the times, yes, it is about RV cardiomyopathy. And then there are different aspects of this disease which are going to be discussed. So I will let Dr. Jitendra Makkad, the whole team is from Jaipur. I'll request him to introduce how he came to constructing this program academically and his speaker team, as well as Dr. Chandrabhan Meena and he, both of whom are going to moderate this session for us. So, Dr. Makkad, floor is yours. Please come in.
Yeah, thank you, Dr. Ashish. Good morning, everyone. And first of all, I thank Dr. Navar and IHRS team for giving us this opportunity. And I'm very happy that IHRS is so proactive for academic learning and teaching, particularly for the our younger colleagues. So this was an opportunity given to us, the Jaipur team. So we are pleased to serve that. And along with me, as a moderator, we have senior professor Dr. C.B. Meena, who is interventionist as well as electrophysiologist working for the largest government sector hospital in Rajasthan, SMS hospital. So he has a very rich experience of many decades behind him. And we have Dr. Nitin Kansal, a very learned senior electrophysiologist working with the very prominent private hospital, Santokba Dullabji Memorial Hospital. He's the director of EP there, and he has a huge experience of electrophysiology, devices, and heart failure management. Then we have Dr. Kush Kumar Bhagat, who is the now director of EP at our hospital, Eternal Hospital, and he has now good experience of complex arrhythmias, heart failure devices, conduction system pacing, etc. And then we have director of our non-invasive cardiology, Dr. Hemant Chaturvedi, who is the pillar of our structural heart disease program as well. That's why I involved him as a specialist echocardiographer. So I think he has experience of maybe millions of echocardiographies behind him now. I'm seeing him for last 15 years. And we are about to join, or maybe we have been joined by one of the most prominent cardioradiologists of Jaipur, who's fortunately working with us at Eternal Hospital now. And she has been trained at many centers, including in Mount Sinai Hospital. So she is not only a cardiac MR specialist, but overall she is an excellent radiologist. So the program this was about our speakers today, and the a special thanks for allotting this topic of ARVD, because we also went into the literature and saw that many things we were missing and we were not knowing about this disease. So not only our younger colleague will learn, but we'll also go back with lot of learnings today. As you said, it is more of a part of arrhythmogenic cardiomyopathies, because many of them have biventricular involvement. And as a terminology, ARVC and ARVD are being used interchangeably, but now most of the societies, most of the literature terms it as ARVC. In comparison to what we started when we were doing DM, it was called ARVD most of the time. But still, they can be used interchangeably. I just, for my younger colleagues, I start with an example of almost 15, 16 years ago in 2007, maybe. I encountered a patient who initially presented to a center with history of syncope and some vague chest pain. So there was deep T-wave inversion in the precordial lead. So they straight away did the angiography. Angiography was normal. So the that showed recanalized LAD. The diagnosis showed recanalized LAD, and then he was sent back. This was a lady. No, sorry, this was a male. Then came back with a frank VT. Then echocardiography was done more carefully by someone, and they diagnosed it as an RV tumor. And cardiac MR was not available at that time. That patient was operated for a cardiac tumor. And I don't know what was removed from there, but in post-operative course, he has a stormy course of arrhythmia. Then he was shifted to our center with arrhythmias only, arrhythmia storm. So we somehow stabilized it with the medical therapy. Then we realized that this may be just, not a tumor, but arrhythmogenic right ventricular dysplasia. And we, after stabilization, we implanted ICD. Still, diagnosis was not clear, but diagnosis became clear when his son came with VT. And same, kind of arrhythmias and same echo picture, and then his grandson. So this is an overall picture of ARVD. With that one single case taught us a lot of things, that how we can diagnose and how we can misdiagnose ARVD. So that's why I'm again thanking you that this is a very good topic. And before we start with Dr. Kush, I like Dr. CV Meena to uh, speak few words about today's program and ARVD. Yeah,
Yeah, Dr.
unmute
Meena,
yourself,
please.
sir. Yeah.
I think we are already late, and I'll request Dr. Kush to start for the first presentation.
Yeah, thank you so much, sir. So I hope my slide is visible.
Yes, very much. Just go on the big screen.
Yeah, perfect.
Okay.
So ARVC or ARVD. So the topic is actually very important, and I am just discussing about the clinical features and diagnosis. So as we all know that it's a genetic cardiomyopathy, and there's a fibrofatty replacement of the RV musculature, and there's ventricular arrhythmias and RV failure. So this is in short the crux of ARVC. So the term ARVD was coined for the first time in 1978 by Frank and Fontaine. And in 1996, WHO and International Society and Federation of Cardiology decided that ARVD has to be considered as a manifestation of cardiomyopathy, as Makar sir mentioned. Hence, the term since then is ARVC, arrhythmogenic induced RV cardiomyopathy. So in general, I'll discuss about incidence, pathophysiology, clinical presentation, how to diagnose, the various criteria, ECGs, and some other tests. Now, as far as the incidence is concerned, it occurs in young adults with a male to female ratio of 2.7 to 1, but the true incidence is unknown. And the prevalence in general population is estimated to be around 0.02 to 0.1%. But in certain regions of Italy and Greece, the incidence and prevalence can be as high as up to 0.4 to 0.8%. And 80% of the disease is diagnosed in patients younger than 40 years. And it should be suspected in all young patients presenting with syncope, VT, and cardiac arrest. As Dr. Makar mentioned, that he was a young patient presenting with probably syncope. So it should be suspected in all patients who present with syncope, VT, or cardiac arrest. Now, coming to the pathophysiology, so ARVC is a progressive disease in which the normal myocardium, it is replaced by the fibrofatty tissue. Usually RV is involved, but left ventricle and septum can also be involved. So by replacement by the fibrofatty tissue, it usually begins in the subepicardium or the mid-mural layers and then gradually progresses to the subendocardium. And there's a particular site which is called as a triangle of dysplasia, in which the RVOT, the apex, and the inferiolateral RV wall near the tricuspid wall. So this is the triangle, and most of the times this fibrofatty replacement occurs in this area only. And then hence there is an islands of scar region, which leads to re-entry circuit, re-entry and ventricular tachycardia, increasing the risk of sudden cardiac arrest. Now, ARVC exact cause is not fully understood, but it is a disease of the cardiac desmosomes. So we all know cardiac desmosome, it is a specialized cell adhesion molecule. And whenever there is some problem in this desmosome, by either it is genetic or acquired or familial disease, then it leads to ARVC. So basically, there is mutation in one or more desmosomal protein, which causes apoptosis, fibrogenesis, adipogenesis, which leads to impair RV function and increasing arrhythmogenicity. So these are the various mutations which can happen in the desmosome protein, desmoplakin, phagoglobulin, ryanodine receptor, which can lead to ARVD. It can either occur as an isolated cardiomyopathy or as a syndrome. So there are two syndromes, Naxos disease and Carvajal syndrome, in which there's palmoplantar keratosis, woolly hair, and either it can involve the RV or LV. So now coming to the clinical presentation. So it is a disease that actually have a temporal progression, and the disease may present differently according to the time of presentation. So a symptomatic form with transient or sustained VT of LBB configuration, and although RBB configuration can also be observed depending on whether the VT is arising from right ventricle or the left ventricle. It can have an asymptomatic form consisting of routine ventricular ectopics, which is detected in either ECG or Holter. Patient can present with RV failure with or without arrhythmias, and there can be a masked form as well, in which patient can present with sudden cardiac arrest, usually during exercise, which is many a times the first clinical manifestation. So the most common symptom is palpitation, second common is syncope, and then there is sudden cardiac arrest and atypical chest pain. So these are the various symptoms the patient can present with: palpitation, syncope, sudden cardiac arrest, atypical chest pain, dyspnea, and patient can even have signs of RV failure, leading to swelling in the lower limbs, ankles, and the abdominal region. So the mechanism of sudden cardiac arrest is the VT, basically the VT, which leads to which degenerates in ventricular fibrillation. Increased risk in patients who have recurrent syncope, younger patients, previous history of cardiac arrest in which there is LV involvement. Now, the important question is how to diagnose ARVC. So first criteria was developed in 1994, which is called as 1994 Task Force criteria for ARVD. And there were the 6 parameters with the help of which we were able to diagnose ARVC. The 6 parameters were, first was global or regional dysfunction and structural alterations in the ventricle, tissue characterization of walls. Then there is repolarization abnormalities, depolarization abnormalities, and arrhythmias in the ECG. And then there's a family history. So this was the 1994 Task Force criteria. The diagnosis was made when either 2 major criteria or 1 major plus 2 minor criteria or 4 minor criteria were met, and the criteria must come from different categories. Now, in this criteria, there was no role of cardiac MRI. In this criteria, no significance was given to the LV involvement. So this was the big drawback of this criteria. So in this criteria, I'll discuss about the depolarization, repolarization, and the arrhythmia part, the ECG part later on in my presentation, and the family history also. But in this, if we talk about the tissue characterization of the wall. So tissue characterization of wall was the major criteria in which biopsy was taken, and fibrofatty replacement of myocardium on endomyocardial biopsy. So these white portions, these are all fat, and this is the epicardial portion. So fibrofatty replacement of the myocardium if seen on the endomyocardial biopsy, was the major criteria. So this was in the 1994 task force criteria. But the problem was that whenever biopsy was taken, we usually take myocardial biopsy from the septal aspect. And we all know that free wall is the predominant wall which is being involved in the right ventricle. So most of the times this was either negative or it is not very sensitive. So now repolarization abnormality can be inverted T waves in the right precordial leads. Depolarization abnormality, I'll discuss it later on. They can be an epsilon waves or localized prolongation of the QRS complex in the right-sided precordial leads. So because of this criteria, it lacked sensitivity for identification of the expanding phenotypic spectrum of arrhythmogenic cardiomyopathy, which includes left-sided variants and did not incorporate late gadolinium enhancement findings by cardiac MRI. So cardiac MRI was not taken into consideration and left ventricular variants were not taken into consideration in this task force criteria. Hence, in 2020, international criteria for diagnosis of arrhythmogenic RV cardiomyopathy was published. So there was, again, after 1994, there was an update in 2010, and after 2010, there was an update in 2020. So the key upgrade was incorporation of tissue characterization findings by cardiac MRI for non-invasive detection of late gadolinium enhancement or myocardial fibrosis that are determinants for characterization of arrhythmogenic biventricular and left ventricular cardiomyopathy. Also, new criteria regarding left ventricular depolarization and repolarization ECG abnormalities and ventricular arrhythmias of left ventricular origin was also provided in this criteria. So this was the criteria. Most important aspect is the 6 parameters which were taken in the 1994 task force criteria: global or regional dysfunction, structural alterations, tissue characterization, repolarization, depolarization abnormalities, arrhythmias, and family history. These were all same, just that the major and the minor criteria were different. This was the 2020 criteria. So, so this was the major criteria by 2D echo, cardiac magnetic resonance or RV angiography, regional RV akinesia, dyskinesia or bulging, and plus one of the following. So I'll discuss the another criteria. And in this criteria, cardiac magnetic resonance imaging feature was taken for tissue characterization. And there were ECG abnormalities for repolarization, depolarization, arrhythmias, and family history and genetics was also taken into consideration. So, but again, in this criteria, this 2020 criteria, there were certain drawbacks. So hence, the latest criteria for ARVC diagnosis, it was published in 2023, last year, in International Journal of Cardiology. And this was published by the European Task Force Consensus Report. So I'll discuss this criteria in detail. So in this report, so they considered ARVC as ACM. This is arrhythmogenic cardiomyopathy. So arrhythmogenic cardiomyopathy, it is a cardiomyopathy that affects the right ventricle, left ventricle, or both the ventricles, and includes the following phenotypic variants: the classic ARVC phenotype, which is also referred to as dominant right phenotype, characterized by RV involvement with no detectable LV abnormalities; the arrhythmogenic LV cardiomyopathy, ALVC phenotype, also referred to as dominant left phenotype, which is characterized by LV involvement with no detectable RV abnormality. And then there is ABVC, arrhythmogenic biventricular cardiomyopathy phenotype, which is characterized by both RV and LV involvement. So this is arrhythmogenic cardiomyopathy, which I think this is the terminology which is used nowadays for ARVC. And then this can either be ARVC, ALVC, or ABVC based on which ventricle is involved. So the proposed criteria, it represent a refinement of this 2020 criteria with particular reference to the identification of non-genetic diseases that may fulfill the diagnostic criteria for arrhythmogenic cardiomyopathy, mostly left-sided variants. So in this criteria, again, the 6 points were same. So in this criteria, there was a different criteria for RV phenotype, for diagnosis of the RV cardiomyopathy, and for the LV phenotype. Now, if we talk about the morphofunctional ventricular abnormalities, so regional RV akinesia, dyskinesia, or aneurysm, plus either global LV dilatation, RV dilatation, or global RV systolic dysfunction, it is considered as a major criteria. And minor criteria when we have only regional RV kinesia, dyskinesia, or aneurysm of the RV3 wall without dilatation or dysfunction. So this is one criteria, which is morphofunctional ventricular abnormalities. So this is mostly diagnosed on echo. Now coming to structural alterations. So in 1994, we need to take a biopsy in order to, there was only one major criteria, and that was endomyocardial biopsy. But now fibrous replacement of the myocardium in one or more than one sample with or without fatty tissue at histology, it is the major criteria. And the minor criteria is RV unequivocal RV late gadolinium enhancement confirmed in two orthogonal views in one or more than RV regions. So basically, this is the MRI finding. So I hope Dr. Ritu will discuss the MRI findings in detail. So this is based on the MRI. So now the MRI, the focus is on MRI for the diagnosis of the structural alterations in the cardiomyopathy. Now, the repolarization abnormality, which is based on the ECG, the major criteria is negative T waves in right precordial leads V1, V2, V3, or beyond in individuals who are more than 14 years old in the absence of complete RBBB. So this was the major criteria, T wave inversion in V1, V2, V3. Minor criteria is T wave inversion in lead V1 and V2, and negative T waves beyond V3 in the presence of complete RBBB, or negative T waves beyond V3 in less than 14 years of age. So this was the repolarization abnormality for the right ventricle. The depolarization abnormality, epsilon wave was given the major criteria in 1994 task wave, but now it's minor criteria. We all know about the epsilon wave, which is a wave which is a low amplitude signal in the end of the QRS complex in the right precordial leads. And there's one more terminology which is called as terminal activation duration, TAD. I'll discuss it in later on. So this was the depolarization abnormality, repolarization abnormality. Then the arrhythmias, major criteria of frequent ventricular extrasystoles, more than 500 per 24 hours, non-sustained or sustained VT of LBB morphology with non-inferior axis. Non-inferior means the arrhythmia is arising from the RV inferior wall. And if it is a inferior axis, that means the RV is arising from the RVOT pattern, which was given a minor criteria. And then again, the family history of genetics, it is same for both the RV and the LV, in which the major criteria is identification of the ACM gene variant in the patient under evaluation, or ACM is confirmed in a first degree relative who meets the diagnostic criteria, or ACM is confirmed pathologically at autopsy or surgery in a first degree relative. So this was the criteria for the right ventricle. Now in the left ventricle phenotype, the minor criteria is global LV systolic dysfunction with or without dilatation. And the cardiac MRI is very, very important for the diagnosis of the LV phenotypic variant of the ARC, which is ring-like LV late gadolinium enhancement of three or more than three segments in the left ventricle. This is the major criteria which is given, which was not present in the 2020 guideline. And again, there was a minor criteria for diagnosis of the LV late gadolinium enhancement, in which less than three segments were involved. So this is in general the criteria, the 6 parameters which were given major or minor criterias, and based on how many the major criteria or the minor criteria patient fulfilled, patient was diagnosed as either possible ARVC, borderline ARVC, or definite ARVC if right-sided criteria was met, or possible ALVC, borderline ALVC, or definite ALVC, depending on how many criteria patient met. The LV criteria, it was either one major or two minor, one major, one minor, or three minor, two major, or one major plus two minor, or four minor. So based on this, patient was diagnosed as ALVC, and if patient had both the involvement, then based on that, patient can be categorized as either biventricular ACM, borderline biventricular arrhythmogenic cardiomyopathy, or definite biventricular arrhythmogenic induced cardiomyopathy. The only thing in this chart, which is very important, that major focus was given on morphofunctional, which is the first criteria, or the tissue characterization, which is the second criteria. This portion, the morphofunctional and the structural categorization can be done very easily by cardiac MRI. Morphofunctional status of the ventricles can be very easily diagnosed with the help of echo. So in short, 2D echo, ECG, and cardiac MRI. So these three things are required for the basic diagnosis of this ARVC. Now, coming to the genetic testing. Nowadays, genetic testing is very important, and we all are doing now family screening and molecular genetic testing. And if molecular genetic testing is positive, so if it is a desmosome, I've discussed about the desmosome. So if it is a desmosome gene variant, we call it as desmosomal gene-related ACM. If it is negative, non-desmosomal, we call it as non-desmosomal gene-related ACM. And if family screening is positive, but the negative molecular genetic testing, we call it as family elusive ACM. And then it can be non-genetic as well. We call it as acquired. If there is no gene, it called as acquired ACM, and we do not find any cause, we call it as idiopathic ACM. So this is how we diagnose this ACM based on this latest criteria, 2023, published by the European Task Force. Both right ventricle, left ventricle, and biventricular involvement can be there, and we can diagnose based on this flowchart very easily how many criteria patient meet: two major, two minor, one major, or two minor, and we can label them as possible, borderline, or definite: ARBC, ALBC, or biventricular cardiomyopathy. So coming to the ECG findings. So in short, we all know about the ECG findings. It can be observed in almost 90% of the patients. ECG abnormalities are there, and it usually shows sinus rhythm. QRS duration of more than 100 milliseconds, 110 milliseconds in lead V1, and epsilon waves, which is a terminal deflection at the end of the QRS complex in lead V1 to V3, which is found in about 30% of the patients, and T-wave inversion in right pericardial leads found in 50 to 70% of the patient. So this is T-wave inversion. So we actually need to have a very high risk of suspicion. So many a times we see this T-wave inversion and we say that this is non-significant or a normal variant kind of pattern, but suspicion should be very high. T-wave inversion present beyond lead V1 with clinical history suggestive of syncope or pre-syncope dizziness, suspicion should be very strong. Then second is the epsilon waves, discussed small deflections just beyond the QRS complex in lead V1, V2, or V3. And complete RBBB can be found in approximately 15% of patients, incomplete 18% of patients. In the presence of right bundle branch block pattern, there is selective prolongation of the QRS duration in lead V1 to V3 as compared to V6. We call it as parietal block, and it is an important hallmark of ARVC. Selective prolongation of QRS duration in lead V1 to V3. So this is basically the right-sided leads, and we see right ventricle parietal block. So the QRS duration in lead V1, V2, V3, it is more than the QRS duration in lead V4, V5, V6 by the ratio of 1:2. So we can see the duration of the QRS in lead V1 is more, and the duration of the QRS in lead V6 is less, which is called as a parietal block. And last but a very important point is prolonged S wave upstroke in lead V1 or V2 with QRS winding. So if prolonged S wave upstroke in lead V1 to V3 is more than 55 milliseconds in the absence of right bundle branch block, it is very, very important criteria for diagnosing ARVC. Now, patient can present with ventricular tachycardia. Most of the times we have left bundle branch block morphology, since the arrhythmias arise from the right ventricle. With it can have either a superior axis or an inferior axis. So if it is have an inferior axis, it can arise from the RVOT. If superior, RV inferior wall. So this is a young patient who presented with this tachycardia during exercise. So basically, this is LBB morphology with inferior axis. So possibly we might think that we are dealing with a case of RVOT VT. So, but this patient was actually having ARVC with arrhythmia arising from the RVOT area. So this is again the ECG findings, especially in the left ventricle. So bottom, if we see, we can see low voltage complexes. So ECG abnormalities and ventricular arrhythmias are associated with the ALVC phenotype. This is a low QRS voltage in the limb leads. Then there is T-wave inversion in lead V5, V4, V5, V6 in limb leads, in precordial lead, sorry. And there is if there is ventricular tachycardia because of ALVC, we will have a right bundle branch morphology. So this is right bundle branch morphology, VT with ALVC, precordial T-wave inversion in lead V4, V5, V6, and low amplitude complex in the limb leads. So this is all ECG features suggestive of ALVC. Now, as I was discussing about, these are the ECG features of ARVC. Epsilon wave, I've already discussed. T-wave inversion in the precordial leads, V1, V2, V3, I've already discussed. Again, the important thing is this terminal activation duration, TAD. So, which is the delayed S wave upstroke, which is interval between the nadir of the S wave, and the end of all depolarization deflection. So if it is more than 50, normal value is less than 55 millisecond. In this patient, this TAD from the nadir of the S wave to the end of the depolarization deflection, so this patient, it was 80 millisecond, which is elevated. So this is again an important point in patients with ARVC. So signal averaged ECG, which is positive late potential. So this is positive late potential and signal average ECG, which is again suggestive of ARVC. So that was the diagnostic criteria. Now, as I discussed about one patient who was having LBB morphology VT with inferior access. So there's a lot of confusion between the RVOT tachycardia and ARVD. But nowadays, the various points which can help in differentiating between these two tachycardias: family history, the sudden cardiac death, which is common, which is rare in RVOT, and this is not so uncommon in ARVD. Family history will be present in ARVD. Frontal plane QRS can be either inferior or superior in ARVC, but it is positive we see in lead 2-3 AVF, which is inferior access in RVOT tachycardia. T-wave morphology is mostly normal in lead in precordial leads V1 to V3. It can be inverted. It is usually inverted in ARVC. Parietal block, I have already discussed. If this is present, then suggestive of ARVD. I think epsilon wave, signal average ECG, and the echo is normal in RVOT. It is abnormal in ARVC and cardiac MRI. I think most of the times, if we go for an echo, if echo is normal, then I think we should go for a cardiac MRI. And if cardiac MRI is one test which will easily differentiate between RVOT and ARVC. So the only thing is that even if we get LBB morphology with inferior access, it can be RVOT tachycardia, it can be ARVC also, because the arrhythmias can arise from the RVOT area as well. So that is why it's very important to evaluate the patient and rule out ARVC. So I think I'll just end my presentation. So myocardial biopsy, I've already discussed. I don't think that most of us, we do myocardial biopsy nowadays. Again, as I already mentioned, usually we take from the septum, from the free wall. We usually don't take because of the risk involved. And most of the times the free septum is spared and the RV free wall is actually involved. So most of the times it is negative. We can do RV angiogram, although I don't think with the MRI, with the advent of MRI, we do this RV angiogram commonly. But yes, we can see aneurysms, we can see hypertrophic trabeculae in the RV area, and this is just the stepwise approach to diagnosis of ARVC. I think clinical history is very important, and suspicion is very, very important. Now, ECG will help, echo will help, Holter will also help, and then molecular genetic testing is, I think it's very important. Cardiac MRI is again very important. Role of EP testing comes when assessment of ventricular electrical instability and guidance for antiarrhythmic therapy. I think Dr. Nitin will discuss about the EP. Endomyocardial biopsy just for histological validation of diagnosis in select patients. So with this, I'd like to end my presentation and hand over to Nabar sir and Sibi Meena sir and Makkar sir.
Yeah, just before I give it to the moderators, push a very comprehensive presentation, and you have set up the tone for the next two presentations. Two remarkable things that you mentioned was, one is that it is a progressive disease. So many times you will see the electrical manifestation as PVC or NSVT coming even before the morphological manifestation. That's where people can miss and call it idiopathic. The second important thing that you said was that the disease starts epicardially and then moves to mid and endocardium. And that's how many times these VT circuits tend to get ablated epicardially. So very good pathological points. I'll hand over to Dr. Meena and Dr. Makkar to make a few comments before we take the next one. Dr. Meena?
Unmute yourselves.
Sure. So as Dr. Kush has very well enumerated about the clinical features, and I think the suspicion is most important. We have to suspect out the disease. We are doing echo day in and day out, but we are not looking at the right ventricle most of the time. We are just focused on the left ventricle. So if somebody is undergoing an echo, I think it's our duty that we should focus on the right ventricle function and right ventricle morphology also. Apart from the ventricular arrhythmias, I have got to the literature. These patients, almost say 25 to 30%, can have atrial fibrillation, atrial tachycardia, or some conduction abnormalities because of the same pathophysiologic mechanism. So if somebody has, especially younger patient, if they are having episodes of palpitation and if you are not able to detect any arrhythmia, I think there are nowadays some reports that we can do the long-term recording, or even the wearables devices that can also be used as far as the diagnosis of the disease and to assess the risk of these concerns. Second, most of the time the arrhythmia is induced by the exercise. So I think the role of exercise testing in these patients is also important. If somebody doing the treadmill and is developing arrhythmia, I think he should be further work up for the confirmation of the diagnosis of the ARVC. These are some of the important clinical points I think we should highlight. And most important again is, as I said, it's a suspicion of the disease so that we can prevent, and to risk stratify those patients who are very high risk, they should be given definitive treatment in the form of ICD to prevent sudden death, because sudden death can be the first presentation in many of the patients. Dr. Makhtar.
Jitendra, there is a role of this sports or vigorous exercise in the progressiveness of ARVC. Can you and Kush make some comments on that?
I would be making on
Yeah,
it.
yeah, I think first thing in management is limitation of activity. So I think Nitin will cover that.
Sure.
Kush had a very comprehensive presentation. Uh, a few, like you mentioned, RVOT tachycardia. So before labeling any tachycardia as idiopathic, whether it is LVOT, RVT, nowadays it is a standard practice to do a CMR and rule out rhythmogenic cardiomyopathy, because then it is between, ablation and ICD what to do first. So in any case, we'll do MRI and label it. Another very important differential diagnosis is sarcoidosis, which can often be confused with biventricular involvement, patchy involvement. So one clinical differentiation is that sarcoidosis people develop AV blocks, but ARVD people almost never develop AV block. They will develop VT only. So if there is AV node disease associated, is more likely, sarcoidosis. So that is one simple clinical feature which can differentiate. And of course, the MR pattern are a bit different in sarcoidosis, which Dr. Ritu will mention further. I think we are behind the schedule already, so we
Sure.
can ask Dr. Hemant to present the next one is Hemant only. No?
That's right. Hemant, your
Yeah.
presentation on echo features.
Yeah, so good morning. Am I audible?
Try to keep it in 15 minutes only so that we can have some discussion and
Sure,
get
sir.
finish the
Please share
Sure,
your
sir.
screen. Please share your screen. Kush, you have logged out, right? You have taken off your screen share.
Yes, I have taken out my shares.
Is it visible now?
Yes,
Yes.
you are audible, visible.
Yeah, thank you. Good morning, all of you. So, as Dr. Kush already discussed about the clinical presentation and the diagnosis and major and minor criteria, so I will focus just on ARVC echocardiography findings, and I will give you a brief presentation about the echocardiography. As Dr. C.B. Meena sir already discussed that right remains always left, because during echocardiography we day to day do echocardiography, and the right ventricle was always remains least important, and anybody is just focusing on the left ventricle, because the wall motion and everything is about the left ventricle. So just when we go for the echocardiography, always and always see for the right ventricle, because it gives many more information what we have. So now I will start my presentation. Yeah. So about the echocardiography criteria, it divides into three criteria: the major criteria, minor criteria, and supportive findings. So first, I will cover the major, minor criteria, and supporting findings of the old one, and then later we will compare about the old and the revised task force criteria, as Dr. Kush has mentioned. So major echocardiographic criteria includes: first is regional dyskinesia, akinesia, or the aneurysm of the right ventricle with one of the below criteria is also present. So there is anything about the right ventricle, it's either it's a regional, it's a focal aneurysm, or is there is any akinesia, along with increase end-diastolic right ventricular outflow tract RVOT diameter greater than or equal to 32 millimeters in the parasternal long axis view, it's a plex view, or in the short axis view, it's 36 millimeters or greater. So along with the regional dyskinesia, akinesia, if in the plex view, if your the RVOT diameter is more than 32 millimeter, or in the short axis view is more than 36 millimeter or greater, and if we go for the correction with the body surface area, in the plex view it's more than 19 millimeter, and in the parasternal short axis view it's more than 21 millimeter of meter square, then it is suggestive of the major echocardiographic criteria for the ARVC. And the fractional area change FAC method, 2D FAC method, fractional area change method of the 33% or less, then it is said to be the major echocardiographic criteria for the ARVC. Now coming to the minor criteria. So the minor criteria include the regional right ventricular akinesia or dyskinesia, and second one is the right ventricular outflow tract diameter, the measurement between in the parasternal long axis view between the 29 and the 35 millimeter, and the fractional area change between the 34 to 39%. So these are the major and the minor criteria. Now there are certain supportive features also, that is a disproportionate enlargement of the basal right ventricle, and there is a secondary tricuspid regurgitation, that is a functional TR associated with the right ventricular dilatation and dysfunction, and moderator band intensely echogenic moderator band, hyperrefractive moderator band. So these are the certain criteria which shows that that could give the suspicion of the ARVC. So coming to this slide, I am giving you a few views of the echocardiography views that we do day to day. In the first is the plex view, and then you can see here that this is a aorta, this is the LA, this is LV, and this is the RVOT in the parasternal long axis view. So this one is the RVOT view, and now this is the short axis view. So this is one is the aorta, this is the LA, this is right atrium, and this is the RVOT view. So as per the major criteria and the minor criteria, we used to measure the length in the RVOT in the plex view and in the parasternal short axis view. And third one is it's the 4-chamber view. You can see that there is a focal bulge and thinning of the akinesia at the RV apex. So these arrows, you can see that here that there is a focal bulge of the RV, there is a focal apical aneurysm, and there is a bulge and the akinesia of the RV apical wall. And in this view, in the below one, that there is a major trabecules, hyper prominent trabecules, that could also be suspicious for the ARVD also. And in the last one, you can see there is a hyperrefractile moderator band. So this is one of the important criteria for the ARVC suspicion. So these are the certain views in which we can say that we can suspect about the ARVC. Now, as Dr. Kush has already discussed about the previous one and the revised task force criteria, so there is a few comparison between these both one. So the major criteria in the original task force criteria was there is a severe dilatation and the reduction of the RV ejection fraction with no or only mild LV impairment, and localized RV aneurysm, either akinesia or dyskinetic areas with the diastole bulging, and severe segmental dilatation of the right ventricle. And this is the in the revised task force criteria, this was further expanded by 2D echo, the regional RV akinesia, dyskinesia, and aneurysm with one of the following. As we have already discussed, the plex, in the plex view, RVOT is more than or equal to 32 millimeter, and in the short axis view, more than or equal to 36 millimeter. And 2D FSC method, the fractional area changes less than or equal to 33%. And in the minor criteria, there are the mild global RV dilatation or ejection fraction reduced with the normal LV in the original task force criteria, mild segmental dilatation of the RV, and the regional RV hypokinesia. And it is further expanded in the revised task force criteria, that is by 2D echo, regional RV kinesia or dyskinesia in one of the following, and lastly, plex view, 29 to 32 millimeters of in the RVOT diameter. And in the short axis view, RVOT dimension is more than or equal to 32, but less than 36 millimeter. And the fractional area change is further expanded 33 to 40% or equal to or less than 40% area changes. So these are the further comparison between the original task force criteria and the revised task force criteria. as Dr. Kush already discussed about the 2023 European Society of Cardiology criteria about the left ventricular involvement also, because there is no significant any changes in the left ventricular because there is just a global LV hypokinesia and there is a dilatation. So there is no hallmark feature or there is no any other specific feature to diagnose the arrhythmogenic cardiomyopathy by echocardiography in the left ventricle. So further, we can say about the sensitivity and the specificity for the right heart dimensions. The mean dimension for the right heart, right atrium and right ventricle, as I will show in your table, in the table, the systolic and the diastolic RVOT and the RV inflow tract dimension were significantly increased in the probants versus the controls. In comparison with the published reference population data, the RVOT in the diastole, whether measured or in its long axis or short axis, was the most enlarged dimension in these 29 affected individuals. And RVOT diameter of more than 25 millimeter, that is a more than 2 standard deviation than the mean value from the reference population, was present in the 100% probands. And an RVOT long axis dimension of the more than 30 millimeter had the highest sensitivity and the specificity of the diagnosis of the ARVC, that is the 89% and the 86% respectively. So the diastolic dimension of the RV taken from the apical four chamber view were the least common enlarged. So we can say that you can see in this table that there is a RVOT in the plex view and the RVOT in the short axis view. So you can see that in the 100% this one, the RVOT dimensions changes is seen in the probands in the 100% cases. The most sensitive cases, the most we can say there is the sensitivity and the specificity for the 89% sensitivity is there for the RVOT long axis dimensions, and it's a 86% specific cases if we can say that there is a RVOT long axis dimension is more than 30 millimeter or mercury, 30 millimeters. So this is one of the very important tool that during the echocardiography we can say that on the plex view we have to measure the RVOT dimension if we suspect about anything that this is not a usual one and this is a dilated. And second one, in the short axis view we also take in consideration about the taking the dimension of the RVOT in the short axis also. Coming to the RV function, so the subjectively the global RV function was abnormal in the 62% of the probants, and the using the quantitative criteria, global RV function was impaired in the 66% of the 29 probants. So this was a trial was done on the 29 probants that was confirmed further for the ARVC. So later on, retrospectively, the echocardiography was done, and it was compared that in 66% cases the global RV function was impaired in the 29 probands, and the regional wall motion abnormalities were present in the 79% of the probands. So basically, we can say that global RV function was reduced. It is not as common as there is a focal regional wall motion abnormality. The focal regional wall motion abnormalities is basically seen in the 86% cases. So there is a mild reduction in the RV function as presented by the fractional area change between 32% and the 25% was present in only 25% of total population. In these 7 probands with the mildly impaired RV function, there were morphologically abnormalities in the 57% and focal regional wall motion abnormality in 86%. So basically, we have to look for the regional wall motion abnormalities much more rather than the global one we can expect in ARVC cases. So this is one of the clip. You can appreciate here that there is a focal bulge here. This is one of our case. We suspect about, and then later on by the cardiac MRI, we get the confirmed diagnosis with the ARVC. Thank you, sir. Over to you.
Well, thanks, Hemant. Dr. Meena, some comments from you?
Yeah, as it's already highlighted, we have definitely major criteria and minor criteria which are already included in the task force. So there is no confusion about that. But apart from that, there are some recent reports, not very recent, but one of the papers which has highlighted the role of tissue Doppler imaging in patient in diagnosing the ARVC. And similarly, there are some recent reports which have looked about the role of 3D echocardiography in the diagnosis of ARVC especially. So they have shown that compared to controls, the three-dimensional echography has significantly reduced global and systolic volumes and increased end diastolic volume and fractional the shortening. So what are the parameters for it? But they are not included. They are not included in the criteria. But I think in the future studies, and if you gather more data about this, they can also be incorporated, because tissue Doppler and 3D is, I think, more sensitive to pick especially in the early stage of the disease.
Yeah, that's a nice comment. Jitendra, something from your end?
Yeah, I think so. One thing is that high degree of suspicion when you are going for an echocardiography of these patients is very important. And you have to look the RV very carefully, whether other than the conventional, you can go for subcostal view to look at for this example, which is now on the screen. So it's a small, akinesia of the RV apex, which raised the suspicion and we could diagnose. And other than, focal abnormalities, as Hemant said, that RVOT dilatation is now one of the major criteria which was not taken into account earlier. And as Dr. C.V. Meena is saying, anything you want to say, Hemant, about tissue Doppler imaging or strain
Yeah, sir.
for ARPG?
Yes, sir. RV strain is now developing in the trend, and we have done the RV strain. We have already started in Rajasthan also, but these are under clinical trials right now, and it needs some validation also to get the certified for the ARVC, because it's under trial right now and under research, and it is not validated and it is not under the guidelines right now. So we are just practicing about the strain one for the RV, because for LV, for the global longitudinal strain for the LV is already validated and taking into account for the chemotherapy and subclinical LV dysfunction patients and all that. But RV strain is under trial and under research one, and we are not doing so much practice right now. Yes, it's going to be a further fruitful for the ARVC detection and further for further RV arrhythmias detection in the strength pattern in the future also. And one thing I will, yes, sir. Yes.
Hemant, how about myocardial contrast echocardiography? Do you require that couple of times when the windows are not good or something?
Yeah, myocardial contrast we do only when the windows are not so good one, or we have a suspicion of any thrombus one and RV scarring like that area. In that case, we use the contrast. But most of the time, because nowadays echocardiography machines are so good and the resolution is so good, so we don't need such one. And the third, again, the 3D echocardiography further helps to reduce for the contrast use. And one thing I would like to add here, that in basic echocardiography, when we go for the echocardiography, we usually see in the apical four chamber view, the RV apex is already obliterated, usually in the normal way. But once you see that on the four chamber, then RV apex is not obliterated, then there should be a suspicion, point of suspicion, that why the RV apex is not an obliterated one. Then there should be something. Either it is a focal aneurysm or there is something else. Another thing, there is a forced trabeculation. If the trabeculations is much more rather than the usual one, and the third one is the hyperrefractile moderator bend. So these three things further raise the suspicion about the ARVC.
Dr. Ashish, I would like to add another new dimension, like all the other, like if you look at the ECG, so AI in ECG is becoming one of the tools. Similarly, for the diagnosis of the arrhythmogenic cardiomyopathy, especially ARVC, there is some recent literature which have looked into the artificial intelligence and machine learning. So if I think if it is incorporated, I think that then the diagnosis will be easier. So once you have that algorithm, I think it will be easier to have suspicion at least for the day, so that we can have the extensive analysis of the RV function.
I think in a suspicious echo, you always need to have a reason like an LBPVC or LBVT. It's from there you take this hypothesis further that you could be dealing with a ARVC in its early form as far as the morphological abnormality is concerned. Sure. So, Dr. Makkad, if you agree, can we move on to the next presentation, which is going to be equally enlightening about MRI?
Yes, 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 sir. So I'll
Sure.
invite
So I
Dr.
think
Ritu to present on MRI findings in ARVC.
Yeah, Dr. Hemant, you have to stop sharing your screen, please. Dr. Hemant, have you stopped sharing the screen?
Yes, sir, I have done.
Okay. Ritu, maybe you can project your screen.
Yes, sir.
Yeah, full screen, please. Yeah.
Sir, I hope you can see my screen now.
Yeah, you are in the presentation
Can you
mode
hear
and
me?
you're audible. Yeah,
Okay.
you can.
So, thank you so much, sir, for having me here. And I'll be brief. I'll mainly focus on the role of MR. So, MR is basically a one-stop shop in various cardiac disorders. And when we are looking at a suspicion for ARVD or ARVC, as we like to call it, we are basically trying to rule out any LV and RV cardiomyopathy. And MR has actually a lot of benefit over other non-invasive modalities because it's accurate, it's reproducible, and there is unrestricted field of view. There is no radiation. We can see the myocardial tissue characterizes very well, and it's very safe in renal disease. And these are our sequences. That's the edema sequence. That's the mapping sequence. These are the scar sequence in which whatever is black is normal and the white is abnormal, which is the scar. Then the perfusion doesn't apply when we do a ARVC, and these are the cine images, which are essentially a better version of echo. We can use them to calculate the EF and the volumes. So going to ARVD, we already know that it's mainly involving the RV, but the LV can also be involved both structurally and functionally. This is involving mostly the triangular dysplasia, its fibrofatty replacement. The clinical presentation has been already very well described. Now, I'll just talk about the MR portion of the 2010 task force criteria. So by MR, I had the major and the minor criteria. Now, on MR, we have these softwares which give us a very accurate calculation of the LV and the RV volumes and function. These are semi-automatic, and so by MR, if we see the any areas of akinesia or dyskinesia or a focal bulge in the artery wall, and the end diastolic volume indexed to body surface area, because this indexing is important because it essentially takes away the variation caused by the body habitus. Now, if we have this volume more than 110 for male or more than 100 for female, and we have a ejection fraction less than or equal to 40, these are major criteria. And the minor criteria would be, again, we need to have some abnormal dyskinesia, dysynchronous RV contraction. But the end diastolic volumes could be between 100 and 110 for index to body surface area for male and 90 to 100 for female. And the ejection fraction could be between more than 40 to less than equal to 45. So when we had two major or one major, two minor, or four minor criteria from different categories, which Dr. Kush had described, ECG and echo and other stuff, then there is a definitive diagnosis. When we had one major and one minor or three minor from different categories, it was borderline. And when we have one major or two minor, it was possible. Now, the problem, I'll just like to show one case here. This was a young male who came with chest tightness on exertion, and now we are seeing the LV also looks a bit dilated. And when we are looking at the RV free wall, we can see this is such a abnormal movement of the RV. The volumes are high. It's essentially dilated. You can very well see the microaneurysms and the irregularity of the RV free wall. And this visualization is actually much better than we see on echo. So this is the beauty of MR. It has a greater degree of resolution, and you can play these images over and over again. You can record them for future reference to see how the patient is doing. Again, you can see the RV free wall, a lot of microaneurysms, large RV volume, which were higher than 110 indexed for patient body weight, and the EF was less than 40% in this patient. Now, this is a still image from the cine images that I showed above. That's a post-contrast image. You can see this some degree of RV scar in the basal RV segments. This white abnormal area is the area of scar, and the same you can see on a short axis image. So the diagnosis of ARVD was fulfilled because we had RV microaneurysms, we had abnormal volumes, and we had poor RV function less than 40%. So by using two major criteria, we had the diagnosis of ARVD on this patient. Now, over decades, as already discussed, 2000 task force criteria used, but then from 2010 to coming to 2024, we had a lot of autopsy investigation, genotype, phenotype correlations, and increased use of CMR. We showed that basically the distinctive phenotype is the fibrofatty replacement of the myocardium, and it can affect only RV, but also the LV as well as biventricular involvement. And this scar is the basic cause of arrhythmias, and regardless of the severity of the systolic dysfunction. So the scar is one thing we cannot see on echo, and that is the power of MR over echo in the diagnosis of over echo and ECG and all the other modalities in diagnosis of ARVD. And therefore now we call it ACM, the arrhythmogenic cardiomyopathy, which is actually the evolution from the original term. And the Padua criteria already discussed. I'll just briefly talk about it once again. So we have a dominant right, we have a biventricular when there is involvement of both LV and RV, and we have a dominant left type when there is no RV involvement but LV involvement. And again, the RV involvement by CMR angio echo, which actually now have taken away the numbers that 110 and 100 is not there. We only say there is global RV dilatation according to our imaging specific nomograms, and we have global RV systolic dysfunction according to our standard nomograms. If we have that, then that is a major criteria. And the dyskinesia or akinesia is a minor criteria. Whereas on LV, we have the depressed LV function, LV dilatation, that is again a minor criteria. And the LV hypokinesia, akinesia, regional wall motion anomalies of the LV is again a minor criteria. What is important is the addition of MR, the contrast MR as a major criteria. If we have a transmural LGE, transmural means the entire thickness of the myocardium, the RV myocardium is involved. And we need to have in greater than 1 RV regions, such as inlet, outlet, or apex. And we need to have it in 2 orthogonal planes, means we have to see it in a short axis view and a long axis view and a 4-chamber view, and either of the 2 images the same pattern should be scarred. So just to make sure that we are not mistaking it for any artifactual area of scar, we have to make sure that the same scar is seen on more than one view. And then if we have a LG scar, this again is a major criteria. So please note that the regional wall motion anomalies, LV, EF and volumes are minor, but the MR has been given much more weightage. And if you have a LG in a stripe pattern, again involving more than one segment of the 17 segment cardiac model, and in 2 orthogonal planes similar to RV, and this has to be in a non-ischemic pattern, which means it will be either subepicardial or mid-myocardial. It can involve the free wall or the septum, but it will not involve the junctional zone. So in the junctional zone, what we mean is, just take you back to that contrast image. So where we have these insertion points, the superior RV insertion point and the inferior RV insertion point, we usually tend to have some degree of scar here, which is okay, except if we are dealing with a hypertrophic cardiomyopathy patient. So this doesn't have much of significance. So that is not considered as a scar for the diagnosis of arrhythmogenic cardiomyopathy. And then biopsy is actually given limited indications because again, we have sampling error. We take it mostly from the septum, which is not the most common site for involvement of arrhythmogenic cardiomyopathy. So when we talk of Padua criteria, what is new? There is introduction of tissue characterization by contrast CMR for detection of the fibrofatty replacement of both the ventricles. And then there are new ECG criteria, which has already been discussed, which are specific for LV involvement. So in patients who have no or minor RV abnormalities and who are not fulfilling the 2010 task force criteria, we can have the diagnosis of left dominant ACM, but we cannot have it just on the basis of the LV phenotype criteria. Because the morpho-functional structural LV abnormalities do not provide a disease specificity, because the non-ischemic pattern of scar is also seen in other heart muscle disorders such as dilated cardiomyopathy, myocarditis, sarcoidosis. So when we want to make a diagnosis of left dominant ACM, in addition to the left LV phenotypic features, we have ACM causing gene mutation. So when we have this MR findings and we have a positive gene study, only then we can make a definitive diagnosis of left dominant arrhythmogenic cardiomyopathy. Otherwise, we might give it as a possible thing, but we cannot make it a definitive diagnosis. And recently, the Heart Rhythm Society actually have broadened the definition of ACM. And they say that ACM is basically arrhythmogenic heart muscle disorder, which is not explained by ischemic, hypertensive, or valvular causes. And that can include sarcoidosis, amyloidosis, inflammatory causes such as myocarditis, infectious such as Chagas disease, and genetic causes. In the most common denominator in all these conditions is the presentation of symptoms and the documentation of atrial fibrillation, conduction disease, and LV and RV arrhythmias. So if we have to make a diagnosis of our right predominant by using Padua criteria, we have the same definitive borderline possible. Then biventricular, when we have greater than one morpho-functional and structural abnormalities of both LV, RV, and left dominant, when we have a structural abnormality plus absence of RV involved. Now, I just want to show a few slides just to show that what are the other conditions that might appear similar. One of these is ULS. Now, ULS basically is an extremely rare disorder, and there is actually no complete absence of RV myocardium. And you can see in this case, there is actually no RV myocardium. Whereas in ARVD, you can see the RV myocardium, you can see the microaneurysms and the irregularity and the dyskinesis of the wall, and you can see a scar. In ULS, a scar is not commonly seen. Then a sarcoid will be with a normal to moderately reduced LV or RV function. Sarcoid can have biventricular involvement and is one of the most important differential, but you will find mediastinal node. And more importantly, the pattern of scar is different. It is subepicardial to midmyocardial. You can have this subepicardial scar, and it involves the RV along with it, and which is the classical hook sign. And if you do a PET again, you see areas of increased uptake. And the other third differential in these conditions, because these patients usually come with rhythm abnormality, so the diagnosis is mostly ARVD versus sarcoid versus myocarditis. And you have in myocarditis this area of increased edema in the myocardium, which is not seen on ARVD. Then when we do a early gadolinium enhancement images, that is just after injecting contrast, we see these areas of patchy increased uptake in the myocardium, which is in a non-ischemic pattern. And again, on the post-contrast image, we see this area of subepicardial to midmyocardial scar. And this is the anterolateral and the infralateral LV, which is again the most common site for LV scar. So if we have increased edema on a search image or on a T2 map, which are the newer versions of mapping we have, which actually picks up which actually creates a color-coded map. And there are certain numbers which tells us that above this number, the myocardium is abnormal. So if you have that increased T2 number, or if you have an early gadolinium enhancement, as in this image, or again, a T1 map is abnormal. And if you have this increase more than one area of non-ischemic pattern scar, then any of two of these are positive, then this is myocarditis and not ER. So to conclude, MR actually establishes diagnosis. It differentiates it from other cardiomyopathy such as sarcoid myocarditis, RVOTBD. And then it can also use to identify additional family members. We can also screen the patients every 2 to 5 years using echo or CMR as the case may be. And if you're suspecting a patient of ARVD, and if a cardiac MR is normal, then it is a high negative predictive value, almost 100%. And now we are there is increased awareness of the phenotypic spectrum of arrhythmogenic cardiomyopathy to include the biventricular and the left dominant variants. The Padua criteria actually is representing a working framework to improve the diagnosis of ACM. And these further need to be validated by further clinical studies and increased applications in future. So thank you so much for your time and for listening. And I'll take up if there are any questions.
Sure. So Jitendra, if I may just pitch in.
Yeah.
Dr. Ritu, we have a lot of difficulty to do MRI once the patient gets an ICD. Do you have any protocols to image better in the presence of that ICD? And why I say is that many times pre-ablation, you may need to know where the scar is and target either endocardial approach or epicardial approach or things like that. So, do you have better sequences to study in a patient who has an ICD?
Sir, if the patient has an ICD, most ICDs are MR compatible. So doing a scan is not a problem, as it is as a problem in a sense it is safe. The problem is the artifacts that comes with the device in situ. Now, if the device is on the anterior wall and if there is RV involvement, mostly we get a good scar image, and we are able to give a diagnosis and able to answer the questions. However, if the question is involvement of the LV, then that is actually a problem because it will depend on the device. Some device give a lot of artifacts, whereas some device do not give that much artifacts. So it is safe. You have to just change the problem is we have to do and see. Mostly we are able to do, but if sometimes the artifact are much, then unfortunately there is something we cannot do that. Because then, I mean, we cannot answer your question, so then we don't like to do it.
So there is a role for an MRI even when the echo is clearly suggestive of an ARVC. So do you think every patient with ARVC before he gets an ICD should kind of compulsorily get an MRI, not only to establish a diagnosis, but to know the geographical distribution of the scar or the enhancement? This
So
question
I
can be
believe a
both for
patient,
Ritu and Jitendra.
I believe a patient should get an MR before putting a ICD. Once you're clinically suspecting it on echo and on ECG, then there should be a MRI done before you plan for a ICD, because MR is a outpatient procedure. It is a day procedure. And that before, if you do it before putting a ICD, it is actually you get the whole heart. You know exactly how much is the scar burden. Or as I showed, sometimes it can be sarcoid, it can be myocarditis. So why put a ICD for those patients? If it is a myocarditis, maybe the patient will resolve on its own. So I just request a day or a two, you delay your ICD by a day or two, get a MR, and then if it is required, you go forward with the ICD or whatever management is best in your clinical judgment.
Is your
Yeah,
practice, Dr. Makkar? Yeah.
yeah, I agree. I agree. Only in one or two patients, I remember that the VTs were so hemodynamically unstable that we were uncertain whether if VT happens during MRI, then what happens. So in
So
that case, I told patient that we'll put IU ICD. After 6 weeks of that, we'll do MRI, whether to see if it is a treatable disease. But right now, you need an ICD because he was stabilized after an arrhythmia storm in the ICU. So such patient, we are little bit skeptical because the availability of defibrillator inside MRI and doing a CPR over there can be a troublesome affair. But otherwise, I agree that ICD should be given only after MRI. Now, your first question, over and above echocardiography, yes, because sometimes we think it is a dilated cardiomyopathy. We are focusing more on LV, and it turns out to be a biventricular arrhythmogenic cardiomyopathy. Vice versa, ARVC can be very dominant, RV involvement can be there, but LV involvement may not be seen in those cases when RV is bit dilated. LV can be ignored. So MRI is very good to see whether both ventricles are involved. And as she said, myocarditis, yes, sometimes we can wait for it to resolve, but arrhythmia is such an issue that we don't want to take chance sometimes. So that is a separate issue. But yes, some treatable diseases, if they can be diagnosed before we put an ICD, that can be very good. And other thing for ARVD, doing MRI for planning of RFA, I'm not sure because most of these will require both endocardial and epicardial approach. But yeah, if there's too much involvement and RV is too much dilated, we generally defer RFA in such cases and do medical management with ICD. If there are focal scars and patient is having frequent VT, we can try ablation. But ablation is not a alternative for ICD here in ARVD. That Nitin will, I think, enlighten more on that.
So, Dr. Agarwal, I want to ask you this question is that, brain MRI is in every lane of Jaipur. But talking about a cardiac MRI, I think there is a question of expertise in reporting. Do you think that expertise in sequences can be easily acquired at many MRI centers and the reporting can be at a core lab or something like that? Because everybody wants to do a cardiac MRI and the reporting for a clinician is not necessarily to the satisfaction.
That is something I agree with you. I mean, it is unfortunate, but it is true. And as a society of cardiac imaging, we are trying to get more and more people trained. We recently had a workshops. We are organizing that workshops, getting more people trained in cardiac MR. For everyone, it is because cardiac MR is a new modality. We, even myself, haven't been exposed to it during my residency training. It is now only I learned it. But the question of remote acquisition of scan and then getting the CD made and probably doing some the scan to be reported at a different center. The thing is, if the scan is supervised and done in a proper way, then yes, reporting is possible at a remote center. But the question is the scan should be acquired and there has to be a dedicated cardiac package on the MR machine. Not every machine, MR machine is capable of doing a cardiac MRI, but there is an add-on cardiac MR package that has to be taken. So you have to ensure that the scan, wherever is being done, they have a dedicated MR software and the technician is well versed doing the scan. The other thing is since these are sick patients, the patients is going to have arrhythmias. So that is actually a problem. Then again, we have this special protocols in place because now we are a high volume. I mean, I wouldn't like to say like that, but yes, we have a good volume of cardiac MRs. So we have those softwares, we have the technician training, and we also have an emergency team nearby if anything goes wrong. Like, so we are very confident when we are doing the scan. But these things have to be taken care of because the problem is in MR when the patient is inside the scanner, you cannot monitor from the ECG reading which is coming outside. Patient is in a magnetic field. So that ECG reading will never be accurate. So either a staff has to stand inside and monitor the patient. So those things, when that remote scanning comes in place, those things have to be taken.
I think the cardiac MRI part, which has been started in Santokpa like 4 or 5 years back, and Ritu comes to Santokpa also, we have seen that not many people were even interested in trying to decipher what the cardiac MRI is telling, even about the viability of the myocardium. So expertise needs to be there before you can go for a definitive diagnosis of these rare disorders where people need to be cognizant of the fact that they have to look for it. So I think we need to go a long way before we can actually start relying on the reports from all the centers of MRI for the cardiac issues.
Sure. So I think we move on to you, Nitin, for synthesizing the whole ARVC. And after your presentation, we can have Dr. Makkad and Dr. Meena offering their closing comments. Sure.
Dr. Ritu, you okay. So I'll share my presentation. Am I audible?
Yes, very much.
Okay. So I have been given the topic of management strategies for ARVC. Now, since the tone has already been set by the clinical presentation, diagnosis making, including ECG, echo, and MRI, we need to go ahead and see how the management of ARVC needs to be done. Now, we always think of the diagnosis of ARVD or ARVC when we come across a person who had exercise-related palpitations or syncope. He is a survivor of sudden cardiac arrest, particularly during or after exercise. If he has frequent VPCs, they can be of any kind, as we know that the triangle of arrhythmia in ARVD can be either from the inflow region, outflow region, or from the apex. So the PVCs can be coming from any of these three regions. Or if we have a VT of left bundle branch block morphology in the absence of any other heart diseases. So what is the to-do list when we have such patients who present to us? First of all, we should evaluate to rule out other genetic and non-genetic forms of arrhythmogenic cardiomyopathies, which would definitely need lot of investigations, which have already been described previously. If we do not get anything specific in them, then we need to repeat yearly evaluations or 2-yearly evaluations, as the disease is a progressive disease, and if we are very strongly suspecting the disease, then we need to do a repeated evaluations. A detailed family history of at least 3 generations and clinical evaluation of relatives would definitely add to the diagnosis or supporting our diagnosis. We should also be cognizant of the natural history of ARVC. What is the natural history of ARVC? Do we need to be really very hyper when we see a patient who can be thought of as ARVC? The answer is no. The disease may occur with no or relatively mild disability and without the necessity for major therapeutic interventions. So this is a very balanced view, and we need to keep it in our mind that we really don't need to jump to, start doing all kinds of things for this patient. Just make a diagnosis and then wait and watch may be a way to go. Predominantly related to ventricular electrical instability, arrhythmic SCD, and mostly in young people and athletes. And the SCD may be the presenting, symptom in some people, in which case you need to definitely look for the other relatives of the deceased person or aborted SCD person to try and see whether we are dealing with arrhythmogenic ventricular cardiomyopathy. Advanced disease do present to us with right or biventricular heart failure. What we need to be very, very, thinking about at all the time is that these people have an increased arrhythmic risk, and structural dysfunction always progresses with exercise. So any person who is a athlete or a high intensity athlete, he needs to be told that this disease will progress and the arrhythmias would progress if he continues to do the same exercise. This task force has already been described by a lot of people. I basically I'm trying to show this because of this endomyocardial biopsy, which has been given a major, part, and then this ARVC having genetic identification. These two things, I feel, are something which we should be very cautious of when we are looking at it. So what is the present status of endomyocardial biopsy? It is useful, particularly useful in identifying systemic or inflammatory conditions that cause arrhythmogenic cardiomyopathies, including sarcoidosis and myocarditis or other diseases, and thus would be helpful in ruling out arrhythmogenic right ventricular cardiomyopathy and ruling in other causes which may be treatable, whereas arrhythmogenic right ventricular cardiomyopathy is not treatable most of the times. But you should know that it's an invasive test. It lacks sensitivity and specificity, has low diagnostic yield. although it has been included as one of the major criteria in the task force for the diagnosis of ARVC. Electroanatomical voltage mapping may improve the yield of biopsy by showing us the sites of scar, but you should be very, very careful that the scar is more epicardial, is close to the inflow region, outflow region, or at the apex, and not in the septum. So the risk of perforation is especially very high when we are doing RV free wall biopsy, and the septal biopsy is usually of no use. Thus, endomyocardial biopsy is rarely performed in the initial diagnosis of ARVC. Genetic testing, it has been said to be a class 1 indications for individuals and descendants with either a clinical or necropsy diagnosis of ACM. Genetic testing of the established ACM susceptibility genes is recommended. But what we should look at is a positive genetic test result is regarded as a major criteria. So it will be contributing up to 50% to the diagnosis of ARVC. But the question is, should we put this much weight on a genetic result for which the true characteristics such as penetrance are generally not well known? Whether the result of the genetic test can be used for risk stratification or management also depends on the known relationship between the genotype and phenotype. But generally speaking, there is a limited evidence for a clinically actionable relationship between the genotype and phenotype. So I still have this kind of a face when I look at the genetic testing. Role of EP study. We all know the protocol for programmed ventricular stimulation is minimum of 2 drive cycle lengths and 3 ventricular extra stimuli while pacing from 2 RV sites, apex and RV outflow tract. And inducibility is defined as the induction of either VF or sustained VT that is lasting more than 30 seconds or requiring termination because of hemodynamic compromise. But having said this, it has a very limited value in identifying patients at risk of arrhythmic cardiac arrest because of its low predictive value. We can actually induce VT and VF in many patients in which it might not be the clinical tachycardia. Then the reported incidence of life-saving ICD discharges for treatment of fast VT or VF did not differ significantly in patients who were and were not inducible at EPS. So, and this is regardless of the specific indication for ICD implantation. So does the EP study have any role? And I'm talking about diagnostic, not the therapeutic one where you're going for catheter ablations. Now let us go to the management, having looked at the diagnosis, and we are very sure that this particular person has a diagnosis of ARVC. Now, SCD and intense exertion, there is a close relation to it, especially in young individuals with ARVC. And physical exercise is a factor promoting development and progression of ARVC. So the recommendations are, and it's a class 1 indication, that if there is a definite diagnosis of ARVD, no competitive and or endurance sports should be allowed. Class 2A, in a definitive diagnosis of ARVD, there should be a restriction from participation in athletic activities except recreational low-intensity sports. Restriction from competitive sports activity may be considered in family members with negative phenotype, that's or healthy gene carriers, that's class 2A, or if we do not know the genotype, that is class 2B. Once we have done lifestyle modification, we have told them that the high intensity sports is a big no-no. Now the therapy for symptomatic patients is usually 3-pronged. 1, arrhythmia management, in which we look at antiarrhythmic drugs, ICD, and catheter ablation, which can be either endo versus epi versus combined. Right ventricular or biventricular failure management is the second prong, and the third one is the thromboembolic management. If there is an RV dysfunction and the patient has symptoms due to dysfunction, then the therapy actually is almost the same as any dilated cardiomyopathy, although you can consider isosorbide dinitrate to reduce the preload in these patients, which may have a better outcome as versus the the patients of left ventricular dysfunction. But otherwise, the management of failure is practically the same. LV or RV aneurysm with definitive thromboembolism already shown, then anticoagulant is required, and also is required for atrial fibrillation or intracavitary thrombosis with definite venous thromboembolism. These patients should be on anticoagulants, and the management of anticoagulation is the same as for any other cardiac illnesses. Antiarrhythmic drugs. Class 1 recommendation is it should be an adjunctive therapy to ICD in patients with frequent appropriate device discharges. It should also be given to people, it's a class 2A indication, to improve symptoms in patients with frequent PVCs and or non-sustained VT. It can be considered as an adjunctive therapy to catheter ablation without a backup ICD. I would not do that ever. In selected patients with recurrent hemodynamically stable VT, and it's a class 2B indication. What you should be very clear that it should not be used in patients who are asymptomatic without documented ventricular arrhythmias and are healthy gene carriers. It's a class 3 indication. Amiodarone by far in the given dose alone or in combination with beta blockers is the most effective therapy. Sotalol may be used because it has both the effects, but it is far less effective than amiodarone and should be used only in young individuals to avoid long-term side effects of amiodarone. But if it fails, you should move on to amiodarone, and you should also be very careful about the QT intervals when you're using sotalol, especially in females. Ability to prevent SCD is unproven for any antiarrhythmic drugs. Beta blockers. The ventricular arrhythmias and cardiac arrest in ARVC are frequently triggered by adrenergic stimulation and occur during or immediately after physical exercise. So it becomes but obvious that beta blockers have to be on board in all patients who have been suspected of having ARVC. Non-vasodilating beta blockers should be the ones to go for. That means you should not actually be going for carvedilol, even if you are thinking of heart failure, but go for other drugs like metoprolol, nadolol, or for that matter, propranolol or bisoprolol. And the dose should be titrated to the maximum tolerated dose for age and weight. And most of these people would have an ICD, so you should not be bothering much about, bradycardia. Of course, fatigue, if it's too much, we might have to come down the dose. Recommendations: class 1 has to be on board for any appropriate ICD therapies, inappropriate ICD interventions because of sinus tachycardia, supraventricular tachycardia, or AF flutter with high ventricular rates. Prophylactic use in healthy gene carriers is not recommended. Heart failure and antithrombotic therapy, clearly class 1 indication, AIS inhibitors, ARB, ARNI, beta blocker, diuretics, we all know about them. Long-term anticoagulation, again class 1 if we have a documented intracavitary thrombosis or venous systemic thromboembolism for secondary prevention. For asymptomatic RV or LV dysfunction, ACE inhibitors, ARBs can be taken on board as it is taken for even asymptomatic LV dysfunction patients, and prophylactic anticoagulation should not be done. This slide was mainly to show that if the patient does not have major RV or LV dysfunction or dilatation, even flecainide can be an option, and this may be used for patients who have failed other medications. ICD. It is most logical therapeutic strategy for patients with ARVC because the natural history is primarily characterized by the risk of SCD and only secondarily by contractile dysfunction leading to progressive heart failure. You should also very much be aware of the fact that 48 to 78% of patients receive appropriate ICD interventions within a follow-up period of 2 to 7 years. That's huge. So what are the recommendations for ICD in ARVC? More than one episodes of hemodynamically unstable sustained VT or VF, you have to give an ICD. If there is a severe systolic dysfunction of the RV, LV, or both, irrespective of arrhythmias, you again need to give it. But that it becomes more like a primary prevention for therapy for ICD. If you have more than one episodes of hemodynamically stable sustained VT, it is a class 2A indication. But I think we should go for it, especially if you're thinking in terms of a ARVC. For major risk factors like unexplained syncope, moderate ventricular dysfunction, and SVT, it becomes class 2A. For minor risk factors, it becomes class 2B. Prophylactic ICD is not recommended in asymptomatic ARVC patients with no risk factors or if they are only healthy gene carriers. So very clear, asymptomatic patients with no risk factors and healthy gene carriers, you can be at ease and not become hyper for that particular patient. Catheter ablation, certain salient points. Acute success is achieved in 60 to 80% of the patients, and the recurrence rates over 3 to 5 years are 50 to 70%. Why? Because the disease is a progressive disease. It has a progressive nature, and the substrate keeps on changing and increasing. Epicardial location of the VT reentry circuits is because the disease starts from epicardium and moves inward. This was very clearly shown by both Ritu and was mentioned by Kush. So this was the main reason why the conventional endocardial mapping of catheter ablation has had high failure rates. Now, the extent of anatomical scar when a voltage mapping is done, it is usually larger on the epicardial side of the RV wall than on the endocardium. So the catheter ablation is palliative at the most. Catheter ablation of VT in ARVC should be considered a potentially effective strategy for eliminating frequent VT episodes and ICD shocks rather than a curative therapeutic approach. It does not reduce SCD and should not be looked as an alternative to ICD therapy. If you take this as your take-home message from this presentation, I have done my job. Exception can be selected cases with a drug refractory hemodynamically stable single morphology VT, but I would still not send this patient off without an ICD. So what are the recommendations? Class 1, incessant VT or frequent appropriate ICD interventions of VT, despite maximal pharmacological therapy including amiodarone. Epicardial approach to VT ablation is recommended only once you have failed endocardial ablation one or more times. And these two are class 1 indications. Class 2A, if you have VTs and you have tried all other therapies other than amiodarone. So that's a class 2A. So if you have such a patient, you should still go to amiodarone and see whether the patient responds to amiodarone and then only decide for catheter ablation, in my opinion. A combined endo and epicardial VT ablation approach is class 2A indication, and still that too in a group of electrophysiologists who have been doing it regularly in their center and are a high volume center. Incessant VT or frequent appropriate ICD interventions on VT who have not failed pharmacological therapy is class 2B. And first choice therapy without a backup ICD is again class 2B. Catheter ablation is not recommended as an alternative to ICD for prevention of SCD in ARVC. This is very, very clear. So my take-home messages would be that exercise increases arrhythmic risk and structural dysfunction progression. Therefore, lifestyle modification is very, very important for a patient in whom either a definitive diagnosis of ARVC has been made or we are very highly suspicious of him having a diagnosis of ARVC. Endomyocardial biopsy and diagnostic EP study are practically of no use. Genetic testing results have to be taken with a pinch of salt, and amiodarone alone or in combination with beta blocker is the most effective drug therapy for ARVC arrhythmic presentation. ICD is the most logical therapeutic strategy, and catheter ablation is not recommended as an alternative to ICD. Of course, the last therapy can be cardiac transplant. Thank you.
I think wonderful. Let's have some comments from Dr. Makkad and Dr. Meena. We have slightly overstepped, but that's okay since it is a teaching session. Let's Dr. Makkad, Dr. Meena.
Yes, sir. So, see, every cardiomyopathy, whether it is, genetic or non-genetic, acquired, whatever, can be arrhythmogenic. The phenotypical difference between these two is that the heart failure is not the prominent presentation in what we call as arrhythmogenic cardiomyopathy, but the arrhythmia is main presentation. So in all these patients, our aim is to manage arrhythmia all the time. Heart failure comes very, very late in their natural history. If at all it comes, most of them would die of arrhythmias rather than heart failure. So that is one thing. Endomyocardial biopsy, as you said, because of not only because of the risk of perforation, but because of the patchy involvement. Unless you use a voltage mapping, as you mentioned, it's very difficult to take the tissue from that particular area. So in most of the centers, I think biopsy is limited to post-cardiac transplant now. Nobody is doing a routine endomyocardial biopsy. As far as EP study goes, I think we have done a couple of EP studies where, there was a syncope and possible ARVC, some indication at echo, some indication at, mildly enlarged RV, but we were not sure whether it is ARVC. So we tried an induced VT and see if there is any, that can just take, it's not in the guideline, but that is one subset where we can do EP study where it is the diagnosis is not definite and there is history of syncope. Of course, for asymptomatic patient, for risk stratification, EP is not recommended. Holter is recommended, but EP is not recommended. And one more thing is that in initial stage of, as it is a progressive disease, in initial stage, there are more risk of sudden cardiac arrest with VF, and as the disease progresses, as scar develops more, there are more chances of hemodynamically stable VT and repetitive VT requiring, more medical therapy and ICD and sometime ablation. So that should also be kept in mind that if it is, early disease with the PVCs and non-sustained VT, I think ICD should be offered early in such patient if you are definite with the diagnosis of ARVC.
Sure. Dr. Meena, your closing comments, please.
Yeah, I think as we have right from the beginning, I said, I think most important is to suspect about the disease so that we can prevent SCD in any individual who is affected with the disease. And from day-to-day perspective, the EP is not important. But as far as if you are doing routinely EP, especially if the patient is undergoing for EP, I think there are certain criteria which can differentiate patients with RVO-TVT versus the ARVC. So in those cases, I think it may be of help in patient if you are taking a patient of the RVO-TVT or float activities. As far as the ICD, I think it is clear indication. But recently, there are updates like you have gene-directed therapy. We have definite genetic marker for the ARVs, especially in arrhythmogenic right ventricle. And there are particular subsets which are highly prone for ventricular arrhythmia. Like patients with plakophilin 2 or the desmoplakin genes, they are highly suspected of sudden death. And recently, there is one report also there said the future is for the gene therapy. So I think we may have some future as far as gene therapy. So genetic testing, if it is possible, should be offered in those patients, especially the unaffected individual like family members. I think this is one of the new paradigm, and we should always try to get the genetic testing most of the patient if it is possible. And finally, as far as the MR is staging or imaging, apart from the echo, MR is now become available at most of the places. The only thing is the acquiring the images and the reporting. They should be improved to have better detection, better diagnosis, and to prevent especially sudden death in young individuals.
So, Kush, Ritu, Hemant, and Nitin, one-liner from each of you if there is anything left that we didn't discuss. Kush.
Suspect ARVC in any patients presenting with syncope.
Sure, Ritu.
Unmute.
You are on mute. You're on mute.
Oh,
Yeah.
I'm sorry. I think so. Everything has been very well covered and explained. I would just like a better understanding and correlation between the radiologist and the cardiologist as we go on discussing different diseases. The more we talk, the better it might be for the patient.
Sure. Hemant?
Further advances in the echocardiography in view of strain echocardiography and the 3D echocardiography, further applications are further needed to provide more insightful information for the ARVC diagnosis.
Sure. Nitin?
ICD. That's what I would go for.
Oh, sure. I think the program has been very clear in terms of clarifying the diagnostic approaches and the therapeutics. And I can't thank Dr. Makkad and Dr. Meena enough for spending their Diwali time, the prime time with us, and creating this program with the help of all the speakers from Jaipur. I must have been a little unkind to them on this aspect, but I'm sure a lot of DNBs have benefited and have attended. I think despite Diwali, we had a similar attendance, close to 100 being on the board with us. And obviously, all of you, the attendees, know that this program gets recorded and put on the IHRS website. And our secretary, Dr. Rakesh Yadav, is kind enough to post it there. And you can again visit this and many earlier programs there at your free time and at your leisure. So I think thanks for this interesting Diwali session from Jaipur. I'm happy all of you agreed and are there. The last session of this year will be about genetics. So once again, for the postgraduates, this is something we haven't discussed in the last 4 years. So again, be there in good numbers so that you can benefit from the session online. Yeah, thank you very much. Thanks, Dr. Makkad. Thanks, Dr. Meena. Thanks
Thank
to
you,
all the
Dr.
speakers.
Ashish. Thanks, IHRS. Yeah, thank you. Bye-bye.
Thank you, everyone.
Thank you. Thank you very much.
Thank you.
Yeah, we log out.